On this episode of the ASC Podcast with John Goehle, we celebrate our 4th year and announce a major new addition to our regular podcast, discuss the COVID-19 vaccine, the new CDC order on international travel, and in our focus segment, we'll discuss peer review.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. The ASC Podcast with John Goehle is brought to you through the generous support of our sponsors, Ambulatory Healthcare Strategies, Surgical Information Systems, Intalere, Encompass Healthcare Data Solutions, Medicus IT, and BHG Patient Lending. This podcast would not be possible without the support of our sponsors, all of whom have been carefully screened for the quality of their products and services and their dedication to the ASC industry. For more information about our sponsors, visit our website at ascpodcast.com and please consider them for your center's needs.
Welcome to episode 121 of the ASC Podcast with John Goehle for January 17th, 2021. We're recording from our studios in Spencerport, New York. This is Sue Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. Joining me is John Goehle, the owner of Ambulatory Healthcare Strategies, and he is recognized as one of the nation's leading experts in the ambulatory surgery industry. Mr. Goehle is the author of over 10 books on the ASC industry and a frequent industry speaker on regulatory, accreditation, and finance issues.
Well, that was take 3.
It was.
As we begin our 4th year of the podcast, you'd think we'd get at least the intro done. But then again, I had to, spice up the script a little bit there on you. But yeah, 4 years. This is beginning our 4th year.
Yeah.
2018 we started. And you remember those days because we were doing it in our dining room.
Yes, but I was not.
You were not.
I was around.
You were around.
But
That's right.
Not.
So we started out with Judy D'Ambrosio was our first host. And then Jenna helped for a while. And then you became our permanent co-host. Yeah. It was that same year, though. It was like April, I think. And you've been doing this for a long time.
I'm kind of I don't want to say a captive audience because I'm not listening.
You can't go anywhere.
It's like, you're the easiest one. Just come on down.
It is nice, though, not to be doing it. Because remember what we did in the dining room? Our dining room had all of the equipment was on the outside of the dining room. And then we would set it up. And then after a while, we just gave up and left it set up all the time.
Yeah.
Which meant we
can't
didn't
take
really
it
have
up
a
and
dining
down
room.
all the time. Yeah.
Yeah. And then we built the studio. That wasn't, we built the studio just very recently, actually. We were actually working out of the office for a while. So we've come a long way. And I mean, I wish people could see a picture of all the equipment we have here with all the screens and the high-tech equipment. And we've come a long, long way in that 3 years that we've been doing it. So thank you to our loyal audience. We get a lot of feedback about the job we're doing. The happiest I think I get is when somebody says it's thanks to you that we passed the survey, and I'm sure there's a lot more involved than just us doing it. People being dedicated, obviously, to following the regulations and putting all that hard work in. But it's nice to be part of that process and being with you for the last 3 years. So. To that end, we do have some big news, though. I listen to a lot of podcasts, Sue, and whenever they announce big news, it's usually like the podcast is ending. And fortunately, that is not what we're announcing, but we are actually going to be adding another podcast. So it will be still called the ASC Podcast with John Goehle, but there's going to be a staff edition now. Now, we've been debating for the last couple of days as to what exactly to call this. So for now, we're just going to call it the staff edition. And what we had found when we were doing interviews of some of our listeners is that sometimes our administrators that listen to the podcast would take sections of the podcast or ask the employees to listen to a podcast that was really relevant to them. So in that discussion, we kind of realized maybe we can put together these shorter like 15-minute clips that you could use during a staff in-service. So we're going to kick that off this week with what will be labeled episode 122, and it's going to just say right on the name of it, ASC Podcast with John Goehle, Staff Edition.
Okay.
And then we'll see how that goes. If we have to create a separate podcast, we might do that also. This is very exciting, though. I think as we were doing some brainstorming, as a matter of fact, we were doing some brainstorming with your daughter, Amy, who is one of our consultants. She gave us a couple of wonderful suggestions as to type of content we could put in there. So, things that we might be discussing, like this episode, we're going to talk about COVID-19, kind of give an update on that and the vaccine, the travel rules. We might talk about sharp safety, hand hygiene. I don't know why we would want to talk about hand hygiene, but it is a very important thing. Radiation safety, which is an in-service that you probably all need. Talking about fire safety, reminding people of race and past. Not that you don't have other ways of doing it, but to put together something that people can remember maybe just before a survey when a surveyor comes in. Emergency preparedness, talking about consents and timing, for example, HIPAA, high tech, advanced directives, respiratory protection programs. So we have a whole bunch of ideas that we're going to be rolling out over the next couple months. And those will be recordings that you can probably use for even a couple years in your staff in-services. So very excited about that. And Sue, I headed down to New York City to visit my car. For those that listened to the last episode, I did have an auto accident a couple weeks ago, and my car is still in New Jersey right now, and still trying to figure out how much it's going to cost to repair it. So I went and visited my poor car and got all of the stuff, shall we say, out of the car. So my other car is a Mustang. So trying to fit all of the stuff that you have inside of a Cadillac inside of a Mustang is no easy task. Trust me. You know, because you've seen the car when I came home. That's quite a way to begin the year, unfortunately. But my main purpose in going to New York City was to get the vaccine. HHC did issue a letter to all of us surveyors, basically giving us authorization to be considered an essential worker. So one of my centers in New York City volunteered to give me the vaccine. And unfortunately, approximately an hour before I was going to get the vaccine, the Department of Health came in and took all of his vaccines for some other purpose, which we must assume was much more important than the staff of the surgery center. So it looks like I'll be going back again this week. They did promise that they would get another shipment in this week, but that's a disappointment. And I guess that gets to the next thing I want to talk about is the vaccine. I know in talking to our surgery centers, there are a number of individuals in these centers that are concerned about the vaccine and the safety of the vaccine. And I know that, we have prominent individuals that are, showing themselves getting the vaccine, that showing their confidence in the safety of it. So, Sue, I had you do a little bit of research on this, and we're not going to spend a lot of time talking about it, but if you can just talk a little bit about the vaccine, how it works, and one suggestion that you made with regard to staggering staff.
Okay, well, we are going to talk more about this in the sort of staff edition,
right?
Where we're going to delve a little bit more into the vaccines. But
and so the reason I'm doing that is a couple of my centers did say this week that they're getting a lot of questions from staff about the vaccine. We would consider as all of us that are involved in this, the administrators, nurse managers, I think we know an awful lot about the vaccine. And this individual suggested that we talk about it in a podcast so that she didn't have to keep talking to all of her staff about it. So whereas we just assumed that everybody knows about it, that really isn't the case. So we will talk about it in a much more depth in the staff edition. But I'm sorry, I didn't mean to interrupt you.
That's okay. The one point I did want to make here is that as you're scheduling vaccines, you may want to stagger the timing for your staff, or if nothing else, just plan your scheduling of procedures and your scheduling of staff, maybe bulk up how many staff you have on for the couple of days after, especially the second dose of the vaccine, because often people are having some fatigue, maybe fever, body aches. Some people may end up not even being able to come into work. I've heard from other centers that people do come into work, but they're, just kind of fatigued and not up to their normal standard of work. So you may have to have a few extra people on or just allow for a slower schedule on those days. And if somebody has had COVID, they'll often have those responses, that kind of more severe response to the first vaccine. But for most people, they'll get through the first vaccine just fine, but it's that second dose that you might just want to be aware of. And I wanted to mention an AORN online survey that I noticed in my email. It's for perioperative nurses with The questions are going to be concerning the nurses' experiences during the pandemic and how it may influence their intent to stay in the workforce. So if you're a member, I would think about participating in that. It's a 15 to 20-minute survey, and I think it's important to have the perspective from an ASC nurse. It's good information to gather because I know it's been a difficult time for a lot of people.
And we've talked about this in previous podcasts, actually, the concern that we have about the future of the workforce, especially the older more seasoned individuals in the workforce here that might be just, considering, leaving. And I certainly understand that. We've already seen that, especially with senior nurses like in management positions. That's one of the reasons we're doing the Administrators Bootcamp is because there's been so much turnover, very recently.
And you can understand somebody in the ICU, they've seen a lot of illness and death.
Yeah.
But in all other areas, like you said, in the perioperative area and the ASCs and any type of ambulatory care, you've just been overstressed and overburdened and afraid of being exposed and, all those different concerns. And
then the CDC had an order this last week that we perhaps need to talk about, especially for anybody that's planning on going on vacation. So you and I will actually be heading down to Hilton Head, but at least it's in the country. But I understand the CDC order has to do with international travel.
So there was a recent CDC order concerning testing for airline passengers that are entering the U.S., whether they're a citizen of another country or whether they're returning to the U.S. as a U.S. citizen. The order came out on January 12th, and it goes into effect on January 26th. So the testing must be done within 3 days before boarding the flight. And this is going to apply whether you've been vaccinated. The one exception is if you have had COVID-19 and recovered, you can get written permission from a healthcare provider or a public health official. And in that case, you'd have to bring your positive test result. I believe it has to be within the 3 months prior. So it has to be a fairly recent infection. And then the written permission letter saying that you've recovered, you're no longer contagious. So to quote from the CDC's page, air passengers are required to get a viral test, which would be a nucleic acid amplification test or an antigen test, basically a test for current infection, not the antibodies, within the 3 days before the flight to the U.S. departs and provide written documentation of their laboratory test result. It can be a paper or an electronic copy to the airline and provide the documentation of having recovered from COVID-19. The airlines must confirm the negative test result of all passengers or documentation of recovery before they board. If a passenger does not provide that, or chooses not to take a test, they have to deny boarding to that passenger. So the CDC recommends that travelers get tested, and this is more a recommendation, whereas the first one was stated as an order. That CDC recommends that travelers get tested 3 to 5 days after travel and stay home or otherwise self-quarantine for 7 days after travel. And even if you test negative, they recommend staying home for the 7 days. So currently, people probably know passengers from the UK are required to show test results in the lobby before they board the plane. Now, what they're looking at is some airlines may use an app called Verifly, Verifly, which will be available on January 23rd for passengers to upload the required documents. Now, this seems so onerous to me because really, I mean, you can't get test results sometimes here
within 5 days.
Where you're familiar with your surroundings. If you're in another country and you have to test within those 3 days before it leaves. And then I did read on their site that if your plane gets delayed, if it pushes you past that 3 days, you have to start over. You have to then go get tested, which means then you're waiting for results, which, it's a lot.
And we know from New York's experience with requiring testing for surgery that getting it done within the 3 days is very difficult, even in the best of circumstances. So and that's why they expanded it to 5 days. So, but this one is more restrictive. Yeah,
and it does seem like it can be more of a rapid test type thing, but and there are a few people that are excluded, but it looks like it's only, law enforcement that's on the job and, of course, the airline crews. So it almost just seems
don't go international. Yeah. Well, I guess you and I won't be leaving the country, but
we weren't going to.
We weren't going anyway.
Darn, to cancel our trip.
Well, and a number of our clients have expressed deep concerns for this, especially with February, March coming up. Like you and I always take time off in February and or March. because it tends to be a downtime in upstate New York, at least. I don't think that's really going to be the case when we go on vacation. We tend to work from our condo, and but as this one client commented, a number of people are going, usually go back to, in this case, she's talking about Israel, going back to Israel, and then coming back from there, and the problems that they're going to have. So she's going to have to she's actually considering putting pretty severe restrictions on employees and their travel, and basically telling them basically indicating that they're going to have to follow these rules. So
and I think probably if it's someplace that is really, really important to go, and you're determined to go, probably if you just check ahead, make sure you have it really lined up that this is when you're going to get tested, that you are going to have the test back in time, because that would get expensive too. You don't want to end up missing a flight because your test is an hour late. Right.
Yeah, and I bet they're not going to refund your money for that.
No.
So, okay, well, let's take a short break, and we'll come back and we'll talk about peer review.
Is your ASC meeting all the infection control requirements in the new normal? Let the team of experts at Ambulatory Healthcare Strategies and the ASC Podcast with John Goehle help you be prepared for the new normal with a range of resources. Be prepared for the infection control challenges of your ASC. Our resources include our free podcast. We'll be adding content to help keep you apprised of the changes and the requirements for infection control. And of course, the podcast is always free.
And the ASC Podcast now has the industry's leading education program for infection control coordinators, which we refer to as the ASC Infection Control Coordinator Training 2020. And we'll be updating this every year, but this training is available at the ASCpodcast.com website. This is a recording of the training program to prepare nurses for the role as an infection control prevention coordinator, or to improve the skills of coordinators that already have that position in the ASC setting. And it was recorded on April 7, 2020. This is a full-day course focused both on the basic skills necessary to become an infection control coordinator and to build on skills that current coordinators already have. Particular emphasis is placed on the infection control challenges of our current environment and preparing for more rigorous surveys in the near future.
After completing the program, attendees will receive a certificate demonstrating that they received the training. The cost of the training is $199.99, and you can get more information about it at the ASCpodcast.com website.
Ambulatory Healthcare Strategy now offers ongoing retainer-based infection control oversight, which includes an annual infection control mock survey, or more frequently, if you wish, review and revisions to your infection control program annually and as needed, annual competencies for your staff on infection control, and that's done during the mock survey, annual training on infection control, also done during this survey, and that's designed for your staff, assistance in investigations of any infections that you might have, assistance in preparing your annual infection control risk assessment, and of course access to all of the AHS infection control resources that our clients have come to rely on.
And for more information on our retainers, visit the Ambulatory Healthcare Strategies website at ah-strategies.com or call John Goehle at 585-594-1167.
So, Sue, peer review has popped up recently as one of the more challenging issues that some of our centers have been facing, and it has been coming up on surveys and especially on new clients. We've been picking up quite a number of new clients recently, and this seems to be a challenge in each of those centers that we've been working with. So peer review is certainly not new to doctors. This is what I find very interesting, is that any of those doctors that have worked in hospitals have had to deal with peer review over the years. And as a matter of fact, in those situations, they're usually required to participate in peer review.
But then they give you such a hard time at the ASC. It's really...
I know. It's very frustrating. They often think they can escape ongoing peer review activities by working in an ASC. And this, of course, is not true. And I think, truthfully, many ASCs really try to make this as simple as possible for the doctors. And, many don't require all doctors to participate in the peer review process, but really you should. A well-functioning surgery center should have, ongoing performance or, participation from everybody. And sharing that load among everybody will certainly make the job easier for those that are doing it. There's really a number of common mistakes that we run into that I've seen over the years. One is having the medical director peer review all the files. Now, we have to remember that peer review is, we have to focus on that word peer, meaning that it has to be an individual that is in the same specialty. Mm-hmm. So, for example, you don't want a medical director who might be an anesthesiologist peer reviewing an orthopod. And we can go on, but I think we get the point there is that it has to be somebody within their own specialty. Another, common mistake is having one doctor do all the peer reviews. That happened in one of our centers, 15 years ago. I remember the medical director was an orthopedic doctor, and he did all the peer reviews for everybody, and that wasn't any more acceptable than having the medical director or the anesthesiologist do that.
And another thing we see a lot is having the nurse fill out the peer review file and just having the doctor sign off on the peer review.
And we actually see that quite a bit, especially when we're taking over a new center. We'll find, the nurses sit down and, they do all this stuff, and then they just walk into the doctor's office or, catch him in between procedures and sign off on it.
And that kind of goes with the next one that you've got noted here, is assuming that peer review is just making sure that the forms exist and that the signatures are on all the forms, that all the boxes are checked.
Yeah.
It's more of a nursing review, making sure that everything's complete. The peer review is more based on that medical judgment and making sure that someone of appropriate or of similar training would have made those same judgments.
Right. So generally those questionnaires that are going to be filled out, we're going to talk about that in a bit, but you want the doctor to be making some decisions. Did this patient come in to have surgery done based upon a medical diagnosis that's appropriate for the surgery that's being done? Did the operative report indicate all the things that showed that, good high quality care was provided? Was, what was performed exactly what was scheduled? And again, fitting in with the diagnosis. Were there any complications? And if there were complications, were they handled appropriately? And by the way, that even goes for vitrectomies. I know we talked about this before, that vitrectomies are a complication, and many doctors refuse to acknowledge that it is a complication. Now, it's not perhaps one of those complications that we have to do a lot of follow-up on, but it is certainly a complication that has to be acknowledged. And then, was the discharge handled properly? Was this patient a proper candidate for the surgery that was performed? And, based upon the pathology that came back, did that support everything else that was done? So that's what real peer review should be. And then we're going to talk about that. Chart review is not the only thing that would make up peer review. But let's go through first, before we get into that, let's go through what peer review requirements are. And Sue, why don't we just start with the conditions for coverage?
Okay, so from the conditions for coverage and interpretive guidelines, 416.45b, the ASC's governing body must have a process reappraising the medical staff privileges granted to each practitioner. CMS recommends a reappraisal at least every 24 months. The reappraisal must include review of the practitioner's current credentials and the practitioner's ASC-specific case record, including measures employed in the ASC's Quality Assurance Performance Improvement Program, such as the emergency transfers to hospitals, post-surgical infection rates, and other surgical complications. The ASC's governing body should use a similar process, including the recommendation of qualified medical personnel for the periodic reappraisal as it is used when initially granting privileges. And based on the evidence, the ASC's governing body must decide whether to continue the practitioner's current privileges without change or to amend those privileges by contracting or expanding them or by withdrawal of the practitioner's privileges entirely. The ASC must also reappraise a practitioner any time that the practitioner seeks to perform procedures outside the scope of previously granted procedures. The ASC should also develop triggers for reappraisal of privileges outside the periodic reappraisal schedule. It's like a tongue twister of reappraisals. In the case of an ASC whose sole member of the governing body is also a member of the ASC's medical staff, it would be advisable to seek the recommendation of outside qualified medical personnel who review not only the physician's credentials, but also evidence of the physician's performance in the ASC.
So what's difficult about the interpretive guidelines is it never actually uses the word peer or review.
Mm-hmm.
Well, it does talk about review.
Yeah.
It's clearly implied, by this, because the only way that you can carry out all of those, 6 items there, is by having a peer actually look at it. And determine that the performance was appropriate. So again, 41645B is the CMS or the Medicare requirements that show us that we have to do ongoing peer review. And I, by the way, Sue, while I was researching all this, I did realize that some of the states have peer review specific stuff. Now, I did not know that. And what popped up in particular was California. So if you are from California, visit the CASA website, the California Association website, and I'm sure that they have a lot of information about peer review in that state. Just Googling it, there was a lot of information available, especially from lawyers, I think, that were putting together programs there.
Yeah.
So let's talk a little bit about accreditation standards, and let's start with HHC. I'm going to make Sue do Joint Commission because it's much more complicated. But HHC is pretty specific, and that's what I like about the way they word it. So that's why, when we're putting together a peer review program, if you follow the format that HHC uses, there's no doubt that you're going to meet the requirements. So in HHC, it is subchapter 3 of chapter 2. And this is what it says. An accreditable organization maintains an active and organized process for peer review that is integrated into the quality management and improvement program. Accredited organizations may determine which healthcare professionals can peer review each other within the following guidelines. It needs to be, number 1, differently licensed practitioners reviewing each other must be privileged to provide similar services to similar patients. And 2, prevailing laws must permit peer review by differently licensed practitioners. So HHC goes on to say each physician, dentist, or healthcare professional is reviewed by at least one similarly privileged and or similarly licensed peer. So that's why you can't have a physician's assistant, for example, doing a peer review of a surgeon. Privileged healthcare professionals participate in the development and application of the peer review criteria used to evaluate the care they provide. And that, again, is important. If you want to get buy-in from your medical staff, you're going to have them participate in putting together that criteria. And if they complain about the review process, this is the best way for them to become, more involved in it, is by pointing out, well, listen, if you give us some suggestions, we would be glad to consider that in the peer review program. So elements of these accreditation standards that HHC would expect to see is clinical care selected for review on an ongoing basis. So this isn't something that you just do every once in a while. The selection process for care to be reviewed applies to all similarly privileged healthcare professionals. All clinical incidents are reviewed in accordance with the organization's peer review policies and procedures. And all privileged healthcare professionals are reviewed at least annually by a peer or supervising healthcare professional. So in the case of HHC, at least, this has to be something that is done on an annual basis. It has to be done regularly. And ongoing monitoring of important aspects of care provided by physicians, dentists, and other healthcare professionals are conducted. And that data is periodically evaluated to identify trends or occurrences that affect patient care. In other words, what we call internal benchmarking. And the data is used to establish internal benchmarks against which performance is compared to identify areas in which improvement is needed. And most importantly here, the results of the peer review is used as part of the process for granting privileges or continuing clinical privileges, as described in other sections of the accreditation manual. And of course, this actually refers directly back to the CMS conditions for coverage. Mm-hmm. Now, Joint Commission is a little more complex, so I'm going to make Sue do that.
So Joint Commission chapter of Human Resources, so HR 0.02.01.03, the organization grants initial, renewed, or revised clinical privileges to individuals who are permitted by law in the organization to practice independently. Before the organization can grant privileges, it must ascertain that the licensed independent practitioners have the necessary credentials to perform their privileges. To grant privileges to licensed independent practitioners, the organization must collect, verify, and assess information related to current competence and the ability to perform the clinical privileges that they have requested. It goes on to say, before granting initial, renewed, or revised privileges to a licensed independent practitioner, the following occurs. The organization's leadership documents current evidence, which includes peer and or faculty recommendations of the individual's ability to perform the privileges requested. And continuing, before granting initial, renewed, or revised privileges to a licensed independent practitioner, the following occurs. The organization reviews information from any of the organization's performance improvement activities pertaining to professional performance, judgment, and continuing, it states, before granting initial, renewed, or revised privileges to a licensed independent practitioner, the following occurs. The organization evaluates the results of any peer review of the individual's clinical performance. Before granting initial, renewed, or revised privileges to licensed independent practitioner, the following occurs. The organization reviews any clinical performance in the organization that is outside acceptable standards. So couldn't we just have put that first two lines and then put bullet points?
What our listeners don't know, too, is that there's a couple things that we had to cut and paste in. Like, how many times did you say as certain instead of ascertain?
Yes, that's what's coming out wrong.
Yeah, it's just the phraseology, I think, is very difficult. And I mean, you know, I have a lot of friends in Joint Commission, and we have a lot of centers that are Joint Commission. But it does go to show how, and I'm just sorry to be blunt about this, how HHC is a lot more succinct about the requirements than perhaps Joint Commission is here. But in truth, they're both saying the same thing. So what is peer review? So let's make one thing very clear right from the very beginning. Peer review has to have buy-in and input from the medical staff that's being reviewed. Without it, you're just not going to be successful in this. And as all of us administrators that have been doing this for a very long time know, getting buy-in, getting the physicians to take this seriously is very difficult. I actually had a discussion a couple days ago with a center who was arguing with me about peer review. This is a center that is considering becoming a client of ours. And they said, you know, we really don't need to do peer review because these doctors have been working here for 20 years. They all know each other, and they're all the best doctors in the community. And I said, that's all well and good, but how do you prove that? And, you know, I'm not saying that she's a liar by any stretch of the imagination. All I'm saying is that peer review is taking information and proving that they're exactly what they are sure they are. And, you know, we have to have, I mean, it's no different than what doctors have to do in order to prove that a vaccine is appropriate. You're not going to just say, listen, we've been creating these vaccines for the last 20 years. Trust us, they'll be fine. You need to have the proof, no matter how old or how long this has been going on. So I know it's frustrating. I know the doctors don't like to review each other, and I know that there's a lot of politics involved in this. I mean, politics with a small p, because people don't ever want to be criticized, for anything that's that might be wrong. But in very good peer review programs, Sue, and you've seen this because you look at a lot of the records too, what we find is that, people that take this process seriously, it becomes a very collegial effort there, where people say, hey, listen, that was fascinating how you did that procedure. Have you thought about this? So again, we're not saying by any stretch of the imagination that we're doing peer review because we think we got bad players there. We're doing it because we need to prove that these people should continue to be part of the program. Continue to be re-credentialed. Yeah,
and most people can. There's always room for some improvement.
Yeah. The problem that I have too, Sue, with organizations that do make that argument is I'm not sure they completely understand the whole quality improvement process or the importance of quality improvement. We take it so seriously. Look what we do with the podcast. We've been listening to our listeners to try to figure out ways to improve. We've got a list of all kinds of things that we need to do over the next year. We do that in our own services, and we certainly expect that of our organizations. We want to see proof that they really are taking this seriously and they really want to do this. I don't want to see people, and I'm hoping that our listeners have the same mindset, that you're going into this process hoping to truly improve the quality, that you're not just doing it in order to pass a survey. And I think another important thing that we have to understand about peer review, it is much more than just a retrospective clinical review of medical records. And that is a lot of times what people feel. And I think that's where doctors get into problems with this or concerns about it, is that it's not just one doctor looking at another doctor's chart. There's so many other things that really are involved in peer review and that need to be part of that decision-making matrix when you re-credential people. So examples, and Sue, maybe we'll just go back and forth on some of these here. So examples of additional areas that you want to review as part of peer review is postoperative infections, drug events such as adverse drug reactions and improper drug administration or utilization.
And complications and unplanned outcomes, including returns to surgery, hospital transfers, or admissions to hospital emergency room or floors within 24 hours.
Adverse complications, or another term is sentinel events if we're talking about Joint Commission, malpractice suits, patient satisfaction and complaints or grievances.
And staff complaints and issues, timely chart completion, cancellations on the day of surgery. For example, an excessive amount might show inappropriate scheduling of patients.
Right. So that's just a list of ideas that you have, but you need to put together as part of your peer review process a list of those things that you're going to be tracking. And anybody that's acutely paid attention to us, which I'm sure every single one of our listeners was, will note that all of those things that we're gathering there are part of the quality improvement process. So really what we're doing here is we're just taking all that information that we're gathering as part of quality improvement and doing it on a physician level so that we can prepare some type of a summary, which gets to the next point, which is you need to be summarizing all of this information in some manner. Now, we in our company use the term physician report card, mainly because I think I just like to get the doctors angry. I don't know. It's not really a term that goes over very well with most doctors. We get quite a bit of resistance, but I use that term because, we as administrators can at least banter it around ourselves, but often, they might attach a name like physician annual summary.
Whatever name that you're going to choose to call it, the report should summarize all of those things that we just talked about. And usually doing it annually is best, as that's required by HHC. Not everybody requires it that frequently, but I always feel like, and I know we've talked about doing something on a really regular basis, then you're less likely to fall behind.
Or forget about it. We know that things that are on an annual cycle really get done, and they'll be part of your normal process, and you won't be, and you're not going to be struggling or scrambling every 2 years in order to get that done.
And you won't miss if there was an issue. You're not going to miss all the signs if it's a more subtle issue that you want to bring up.
It's important to protect the reviewers because I think. So a well-run quality improvement program, a well-run peer review program is going to not be discoverable in the event of a lawsuit. In most states, there are some exceptions, unfortunately, to that in some parts of the country. But as I've mentioned before, I do some medical legal work, and even as the expert witness, I'm not allowed to see peer review information or quality improvement information because they don't want that information to get out as part of this. And that's an important part of peer review is understanding that you're protected in doing these reviews and that this is a good thing. And the government recognizes that in the regulations and in the law so that there is an opportunity for people to do this evaluation without a concern that they're going to get into legal trouble, at least not through the peer review process.
Yeah, it could be a way of protecting each other, really, if they're noticing things or trends or something they have questions about, if they can bring it up in a helpful way.
Right.
A non-confrontational way, then it may save some problems farther on.
So unfortunately, the elephant in the room here is the fact that most of the doctors that work, that's probably not fair to say most, that's really not accurate, but many of the doctors that we work with in surgery centers just really don't want to do this. And I know the reasons, and some of them are legitimate. I don't have the time. I'm so busy. During the pandemic, nobody has time to do anything right now, at least not when we're working. And I do understand that, but it is an important part of our process. It's an important means of assuring that, we do maintain high quality care in organizations. And of course, this is one of the reasons that I'm so passionate about what I do is that I'm concerned that, a few bad actors out there can really make for a bad reputation for our industry. And the more that we can demonstrate to the outside world that we are able to do good self-policing of our peer review process and to have these processes in place and we take it seriously, the more that the healthcare industry and patients will take us seriously also.
And the bottom line it's required.
It is required. So. That's right. So if all else fails, at least tell them they have to do it.
Yeah.
So let's take a short break. And when we come back, we'll go over our quick list of upcoming events in the ASC industry, which seems to be getting smaller and smaller, Sue. We'll be right back.
In this segment, we discuss other learning opportunities in the ASC industry. If you would like your event to be included in the podcast, please send the event information to info@ascpodcast.com.
Now, since the New Jersey Association has been very good about providing me information about their upcoming general membership meeting, I thought I would spend more time than normal on one of these, maybe encourage other organizations to get us this information. Now, one of the reasons that they've been so good about it is because I'm speaking there. Mm-hmm. The New Jersey Association of Ambulatory Surgery Centers virtual general membership meeting is January 20th, 2021, and it goes from about 11 a.m. through about 3:30, and it's all virtual this year. And there's a number of wonderful sessions, including a welcome from our dear friend Jeff Shanton, who's been on our podcast before, a regulatory and legislative update, an update from the Office of Civil Rights, HIPAA regulator, talking about compliance priorities for 2020 and beyond, a segment on ASC budgeting, a program called Managing Your AR and Keeping Your Receivables Under Control by this strange gentleman by the name of John Goehle, coding's impact on ASC revenue cycle performance. There's going to be a break and then some opportunities to meet with vendors. Then a discussion about preparing for a survey with the New Jersey Department of Health. What a great opportunity to find out what they're up to. Discussion about how staffing models in healthcare have changed due to the COVID-19 crisis. That'll be interesting. Discussion about proactive steps to position your ASC for successful payer negotiations. And then finishing with an ASC technology trends in 2021 with our dear friend Nelson Gomes.
And ASCA 2021 is virtual again this year, April 26th. May 3rd and May 10th. The same content, but it will be delivered virtually, and we are hoping to get back in person soon.
Yeah, and I think I'm doing 2 sessions. I am a little confused right now. I didn't write this down, but I believe I'm doing 2 sessions for this conference in April. I guess I better write those those slides. And then the 2021 Virtual Infection Prevention for ASC's seminar is February 1st and 2nd. Lori Rodricks, one of our guests here on the podcast a couple episodes ago, was going to be one of the speakers. And with this conference, you get resources you need to develop and maintain an infection prevention program that protects your patients and your ASC. And this course is comprised of 2 4-hour days and will also help you prepare for the Certified Ambulatory Infection Preventionist Program, the CAPE program.
In the 2021 Virtual Management Essentials for ASC Administrators Seminar, March 1st and 2nd, and John will be one of the speakers.
And it helps ASC leaders to be well-informed and prepared to meet all of the applicable federal regulatory requirements and accreditation organization standards. Hear from expert faculty with extensive experience in ASC management as they discuss what ASC leaders need to know about compliance, finance, and quality management. And Sue, this program is actually the old CASC review course, which they have rebranded, shall we say, to focus a little bit more on things that all ASC administrators need to know.
And just to remind people of our credentialing workshop recorded live on December 8th, it is available by going to the ASC Podcast website at ascpodcast.com.
And we've got a lot of really good feedback about the credentialing workshop, and all of our clients are getting access to this for free. But if you are not a client and are interested, definitely listen to it. It's a full day workshop, and it's particularly helpful, Sue, I think we'll agree, for the people that actually do the credentialing, though I encourage administrators to listen to it also. But this is really meant to be down and dirty and a good discussion about how to actually do the work. And, of course, the Administrators Bootcamp is coming up. Prepare for the challenges of ASC administration by participating in the ASC Administrators Bootcamp. We do have 1 slot left for the winter cohort, and then we will have another one scheduled for July, and not ready to announce the dates yet, as well as a recorded module that will be available within the year. So this is a comprehensive program to prepare ASC administrators for the challenges of leading and managing an ambulatory surgery center. And this program really is designed for new administrators that wish to enhance their skills, and administrators that wish to prepare for certification. It is the industry's most comprehensive preparation for the role of the ASC administrator. And lastly, we just want to remind everyone to become a patron member of the podcast. The Patron Member Program, which is also known as ASC Central, is an exclusive membership website that provides one-stop ASC regulatory and accreditation compliance, operations, financial management resource to business administrators, nurse managers, and business office managers. Resources in the patron program include access to some of our virtual conferences, links, policies and procedures, forms, drills, discounts on services and books, and access for free for AEU credits. Membership helps to defray the cost of producing the podcast, including research staff, travel cost to conference. I might as well just take that out. Travel cost to conferences, equipment cost, which is a big part of what we do here, and production cost, which is also big. So for more information, you may visit asc-central.com. Well, that's it for this episode of the ASC Podcast with John Goehle. Join us again, and please consider becoming a patron by visiting that website at ascpodcast.com, and spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. The sound editor for this episode will be Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite. Jenna Alvarez, who is out right now with a child, but she will be back. Judy D'Ambrosio, Alex Borneman.
Any child.
Is my grandchild, yes. Alex Borneman, Zach Caloritis, and Lori Rodericks. Music is provided by Media Sushi and Mike Noah. The ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. We would like to thank our sponsors, Ambulatory Healthcare Strategies, Surgical Information Systems, Encompass Healthcare Data Solutions, BHG Patient Lending, Medicus IT, and Intalere. For more information about our sponsors, visit our website at ascpodcast.com. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.